Hi, everyone. So our clinical topic is about inflammatory bowel disease. And in this presentation, we will be focusing on colorectal screening, FIT test versus the Cologuard multi-target stool DNA test. So the purpose of our presentation is to determine which colorectal cancer screening tests are best suited for specific patient populations that present to our established clinic. So for the objectives, we wanted to compare and contrast results and efficacy of the FIT test versus the Cologuard multi-target stool FIT DNA test for colorectal screening. We also wanted to differentiate which patient populations qualify for and would benefit most from these individual tests. And we also wanted to consider patient acceptance, cost, and convenience while selecting these testing methods. So we used primary literature as a guide to what is indicated and what should not be used in certain populations. As you can see in the results section on the right, we found a study that talks about multi-target stool DNA testing for colorectal screening. After looking at the results of the study, we concluded that when we compare the multi-target stool DNA testing and the FIT testing, the DNA test was superior in terms of sensitivity. However, the FIT test was superior in terms of specificity when detecting advanced precancerous lesions and colorectal cancers. Hi, everyone.
As stated on the previous slide, our clinic will be providing screening tools to help understand proper treatment of irritable bowel disease and colorectal cancer. The screening tools I am talking about are the FIT test and the Cologuard multi-target stool DNA test. These tests will help define the specificity and sensitivity using proper biomarkers. The use of these two tests will increase the chance of a tailored treatment for each individual patients that will be at our clinic. The FIT test and the Cologuard multi-target stool DNA test are not limited to for the use of irritable bowel disease. In some incidents, the test can help discover cancers early on in patients. So patients at higher risk for developmental cancer can be among one of those patients to utilize these tests, and many more. Then adequate treatment can be followed since by the biomarkers of these tests detected potential cancers or not. The use of these will help to have the proper treatment, not only for the disease state or if it's cancerous. So by testing these markers with these screening tools, patients will have a higher life expectancy, which is the goal for many patients.
So now I'm going to give you a little bit of information on the Cologuard multi-target stool DNA FIT test. So this test provides qualitative detection of colorectal neoplasia-associated DNA markers, as well as the presence of occult hemoglobin in human stool. A positive result with this test may mean multiple things, one being the presence of colorectal cancer, and another meaning the presence of advanced adenoma. All positive results should be followed by diagnostic colonoscopy. This test is indicated for males and females with the age of 50 or older who are at typical average risk for colorectal cancer. Keep in mind that there are contraindications and cautions to using these tests, as well as advantages and disadvantages. The Cologuard multi-target stool DNA FIT test should not be used if someone is experiencing bleeding hemorrhoids, bleeding cuts or wounds on hands, rectal bleeding, diarrhea, or is on their period. Contraindications for use in this test include those with a history of colorectal cancer or adenomas, those who had a positive result from another colorectal cancer screening method within the last 6 months, or those who have conditions associated with high risk for colorectal cancers. These include IBD, chronic ulcerative colitis, Crohn's disease, familial adenomatous polyposis, and family history of colorectal cancers. How this test works is that it uses the entire bowel movement to detect colorectal cancer and precancer. Every day, the colon sheds cells, and these cells are picked up by the stool. Some advantages of this test include that it has 87% specificity and detects 11 biomarkers. This test is easy to use and does not include any prep or anesthesia. This test is also covered by some insurance plans. Some disadvantages include the fact that it is more expensive than the FIT test. There's possibility of false positives due to bleeding for other reasons. There can be negative results, and these do not indicate absolute absence of cancerous cells. And finally, this is not a visual examination.
So in this slide, we're going to be talking about the fecal immunochemical test, or the FIT test. So just to give you a little background, the primary purpose of the FIT test is to basically help us find colorectal cancer or precancerous polyps pretty early. So most polyps do not cause harm, but some of them can become cancerous. So it is very important to identify those pretty early so that we can remove them. Both colorectal cancers and polyps, they basically release trace amount of blood that is excreted with stool. And blood in the stool can be one of the first signs of colorectal cancer. And obviously we want to diagnose colorectal cancer early so that we can make it easier to treat. The FIT test is used as a screening tool, meaning that it checks for signs of cancer polyps in people who do not otherwise have symptoms of these conditions. The FIT test is not used in people who are already known to have colorectal cancer. So blood in the stool, which is kind of one of the limitations of the FIT test, blood in the stool can have causes other than polyps and cancer. You could have hemorrhoids, ulcers, any GI bleeding could cause blood in the stool. So it is not necessarily cancer. So the FIT test cannot determine the specific source of the blood or what it is causing. It just tells you that there's blood in the stool or there's blood present. So we might need more specialized or invasive testing if blood is found, depending on the symptoms of the patient. So going along with what I've discussed in the previous slide, some of the advantages of the FIT test include that, for example, it is non-invasive, unlike the colonoscopy. So patients might prefer this over colonoscopy for this reason. It does not require bowel prep either, no sedation, and it's very convenient because it can be collected at home. So patients find that pretty convenient and easy, and you don't really need any diet or medication changes prior to the FIT test, unlike some other tests. Some disadvantages: it is a less sensitive test. So if we do find blood in the stool, we might require that you go ahead and get a colonoscopy, for example, a more specialized, more sensitive test. It fails to detect some polyps and cancers. And as I said, additional tests may be required. It has a lot of high false positives, and it is costly if there is no insurance coverage for some patients.
Hi, everyone. So for this slide, we're going to talk about a study that we found about multi-target stool DNA testing for colorectal screening. So the objectives for this study is to utilize an accurate, non-invasive test that could improve the effectiveness of colorectal cancer screening. So the study design was a cross-sectional study that included 90 sites throughout the United States and Canada. And it was approved by the Institutional Review Board at each site. The primary outcome was the ability to detect colorectal cancer via DNA testing with disease stage determined using the American Joint Committee on Cancer Staging System. So for the study population, we targeted a population of participants who were asymptomatic between the ages of 50 and 84 years old, who were considered to be at an average risk for colorectal cancer, and who were also scheduled to undergo screening colonoscopy. Now, we did take factors into consideration with patients or participants who were not allowed to participate in the study, and that excluded patients who had participated in any interventional clinical study within the previous 30 days. Any patients or participants who had undergone colonoscopy within the previous 9 years, any personal or family history of colorectal cancer, positive results on fecal blood testing within the previous 6 months, and patients who were or participants who are unable or unwilling to provide written informed consent. So these factors were kind of our exclusion criteria for participants in this study.
So in terms of the results of this study, there were 9,989 participants who were evaluated. 65 of them had colorectal cancer and 757 ended up having advanced precancerous lesions on colonoscopy. So the bar graph above compares the FIT and Cologuard tests in terms of their sensitivity and specificity. Starting on the x-axis, the first three results focus on the sensitivity of both tests. The sensitivity for detecting cancer, advanced precancer, and suspicious polyps was much higher in the Cologuard group in comparison to the FIT group. However, on the far right of the x-axis, you can see that the specificity between the two tests were not inferior to one another. So meaning there were more false positive colorectal cancer results in the Cologuard group. So to sum up these results, Cologuard was able to detect significantly more colorectal cancers than the FIT test, but also had much higher false positive readings, which can cause much unneeded stress on patients. This slide provides a comparison between the previous study and Cologuard's current recommendations for patients using this product. One potential downfall of this study is that it only included individuals 50 years and older, while Cologuard recommends starting the screening process at age 45. Based off this comparison, it leaves a lot of question marks in regards to whether the 45 to 49 age range would benefit from this type of screening. However, Cologuard did provide research on their website which supports screening in ages younger than 50 due to the change of the American Cancer Society's guidelines stating 1 in 7 colorectal cancer patients were under the age of 50. The previous research that was discussed has exclusion criteria correlating to the current eligibility criteria for Cologuard testing. For example, those with a personal or family history of colorectal cancer, high risk for colorectal cancer, IBD and certain hereditary syndromes, and history of adenomas are not eligible to take this test. The Cologuard manufacturer did acknowledge the rate of low specificity with this test based off results from a variety of primary literature. So they highly recommend patients to seek further recommendations from their healthcare provider if they do happen to receive a positive test result. Cologuard is a highly useful screening tool in detecting colorectal cancer and should be implemented routinely in practice. This specific technology should be used every 3 years in eligible patients at their wellness visits within an ambulatory care setting. That way, these cancers will be caught in its earliest stages and treated promptly to prevent further complications down the road. One downfall of this test is that there is high exclusion criteria, which makes it inaccessible to those at a high risk of developing colorectal cancer, such as those with IBD. Cologuard does require a prescription, so an ambulatory care clinic would be a perfect setting to provide this technology. Pharmacists are the most accessible healthcare professional, so utilizing them gives patients ease of access to Cologuard tests, proper education on the product before use, and better understanding of test results along with further recommendations.
So to wrap everything up, I'm just going to be talking about our final recommendations based on the studies that we just went over in the previous slides. Therefore, in conclusion, when comparing the DNA test versus the FIT test, the DNA test showed higher single application sensitivity when compared to the commercial FIT test. And this is both for detection of colorectal cancer and advanced precancerous lesions, although the DNA test showed lower specificity. However, colonoscopy is still considered the gold standard method of testing for colorectal screening. Our study showed that both these options provide an option for patients that don't want to undergo invasive procedures. So a key point to keep in mind is that considering all the points brought forth from our studies, the investigators cannot determine which test or strategy is better or preferred. However, there are certain situations that we can recommend one test over the other. For example, a DNA test is beneficial when early detection of these cancers is warranted as the test is higher in sensitivity, as well as if a patient received a false negative test previously and wants to try another fecal occult stool testing method, this would be a good option for them to try. And when looking at the FIT test, a scenario in which we would recommend this test over the DNA test is when a patient may have age-related variations in specificity due to lesions that may have been missed on a colonoscopy, and this is more likely to be seen with patients older than 70. So to look at some similarities between these two tests, just to wrap everything up, we have that they are both non-invasive, do not require a bowel prep, so that makes it easy to use and can be done at home, which is kind of an advantage for patients, like I mentioned before, that don't want to undergo invasive procedures. But like I also previously mentioned, colonoscopy is still going to be a patient's best option when faced with discrepancies from one of these fecal occult stool tests. So the final conclusion statement, as seen on the poster slide, is that when comparing the multi-target stool DNA testing and the FIT testing, the DNA test was superior in terms of sensitivity. However, the FIT test was superior in terms of specificity when detecting advanced precancerous lesions and colorectal cancers. And thank you for watching.